going to be very challenging to come up with treatments that affect both pain and structure. And I don't know that the FDA approach or any approach we've talked about does that in ways that are likely to be terribly successful. And I'm not sure I don't mean to say there is such a magical approach. I'm not sure there is. I wanted to make a suggestion that the group might consider a hierarchical analytic approach, which would, and it's sort of, the FDA sort of already takes this approach in many ways, which is to say the primary outcome here is patient pain and function. That's what we care most about, and that's what patients need to experience with this treatment. And if you reach significance on a pre-specified primary outcome that relates to pain and function, then as a secondary outcome, we might give you the opportunity to ask for a structure claim, but only if that primary is positive. And that would solve some of the problems we've been talking about, but it may be that there's no such treatment that could accomplish that. But I just want to throw that out as an idea. I'm nervous that a variety of companies are going to try to pursue and want to pursue something where they make both structure and pain claims. And I agree with Tim. I think this is going to be pretty challenging. If pain gets a lot better, people walk on it more, they damage it more, and structure can get worse. And so the two may not go together longitudinally. So let me start it off with that. I actually also have some granular suggestions about the FDA version and other ways of assessing pain, but I sort of thought those were less critical. Let me quickly say to Yura Kim, wonderful idea. You can reduce the number needed, as has been done in rheumatoid arthritis, by increasing the initial pain requirement. So you took all of those who were in the progression cohort in OAI, and their range of WOMAC pain at baseline is very wide. You could require that people have a WOMAC pain score of 6 or greater, 7 or greater, and then the number required for these trials would be much less. That's a reasonable way of getting at the numbers challenge that is part of what happened as you did your analysis. And then there's a variety of other ways of evaluating pain that we haven't used in OA and that we should be using in trials, including activity-evoked pain, both walking and staircase-evoked pain. There's wonderful recent work on staircase-evoked pain, which is very sensitive to change outcome and is likely more sensitive to change than WOMAC. And I suggest that we begin thinking about that.